So hello and a very warm welcome to this podcast entitled Thinking About Cardiology. My name's Ed Wallet.
And I'm Rashmi Patel. And in this podcast, we're going to go through a summary, really, of how to approach various different topics in cardiology, going through clinical features, the various different types of investigations you can do, and different modalities for treatment.
I think an important initial point to make is that often if you read any of the large textbooks of clinical medicine, say Kumar and Clark or Davidson's, you'll find that in a chapter that's particularly devoted to pathology of an organ system, say cardiology or respiratory disease or GI disease, often the first part of that chapter is devoted to talking about the most common presenting complaints, the most common signs that you see, important investigations and treatments, particularly those things that are specific to that condition. And that's really the point of this podcast, is to just highlight some of those and to give some handy tips on useful things that actually might be applicable to a number of different specialties as well.
Absolutely. I think that's right. Having this framework, which can be applied not only to cardiology, but any other topic, which just helps order things and helps you learn about the topic a bit more easily.
No, exactly.
So in terms of cardiology, these are some of the clinical features which are particularly associated with cardiological disease, the symptoms, in other words, what the patient presents with in the history, and the signs which you find on examination. Now, of course, in cardiology, the cardinal symptom of cardiac disease is chest pain.
You must learn about chest pain.
Yeah, very important topic to learn about. And in addition to that, shortness of breath, and syncope, particularly if the patient has got arrhythmias, ankle swelling as well. And I think it's important to highlight as well that the shortness of breath, ankle swelling, and the fact that a lot of the time disease in the cardiovascular system is often coexistent in the respiratory system, and the patient might present with symptoms and signs in both.
Yeah, it's a very important link there. Yeah.
So what about some of the signs which you find on examination? In systemic examination, you always have a systematic approach, starting off with the hands, working your way up the arms, and then into the particular system. And that's the same for the cardiovascular system as well.
Of course, yeah.
So starting off in the hands then, what are some of the things you can find? Well, one is clubbing of the fingernails, and of course clubbing is one of these things which you hear and then you think, oh my gosh, there are 21 different causes of clubbing. For cardiovascular disease, two of the most important causes are subacute effective endocarditis and congenital cyanotic heart disease. And then moving on to the pulse. I mean, what do you think about the...
I mean, one of the key features of obviously the cardiological examination is feeling the pulse.
Absolutely.
You want to feel for the rate of the pulse. Is it slow, in which case it's a bradycardia? Is it fast, in which case it's a tachycardia? And the kind of figures I like to have there is less than 60 is a bradycardia, greater than 100, or some people would say 90, is a tachycardia. However, you also want to feel for the rhythm of the pulse. Is it regular or is it irregular? If it's irregular, is it irregularly irregular, in which case it's most likely atrial fibrillation, or is it regularly irregular, which can be due to certain types of heart block, but mainly focus on irregular or regular. You also can feel for the character of the pulse. Now, often this is better done at more central pulses, such as the brachial or the carotid, but there are some important signs that can be picked up. For example, a slow rising or anacrotic pulse is very typical of aortic stenosis, while a water hammer pulse is very particular to aortic regurgitation.
That's right. And sometimes people wonder how you can sort of feel for a collapsing pulse, and I always found this a bit confusing, what you have to do. But the way I do it is once I found the pulse at the wrist, all I do is, well, first of all, ask the patient if they got any pain in the shoulder joint. That's very important because you'll be moving their arm. And then just gently rest your four fingers around the wrist and lift up the arm. And you will just feel the pulse, it will collapse against your fingers. You'll feel it collapsing against it if the patient has a collapsing pulse. And actually, moving on to the blood pressure, it links in quite nicely there, because the blood pressure is not only useful to work out whether the patient is hypertensive or hypotensive, but the other useful thing you can look at in the blood pressure is the pulse pressure. In other words, the difference between the systolic and diastolic. and that can relate to the same signs which you find when
Exactly.
you're feeling the pulse. So
Yeah.
a narrow pulse pressure could be associated with a slow rising pulse of aortic stenosis, whereas a widened pulse pressure could be associated with the collapsing water hammer pulse of aortic regurgitation.
Exactly. If we move further up the arm, we can look at the JVP. Now, JVP interpretation is really a bit of a mystery, and there are lots of different waves described, A waves, C waves, and various valvular pathologies of the right side of the heart can cause various alterations in these. At a basic level, however, you should simply be able to decide, is this JVP elevated or is it not elevated? If you see the typical features of the JVP, so the double pulsation that is you are able to eliminate on touching, that responds to pressure on the abdomen, all of those features. If you see that right up more towards the mastoid process and up towards the ear, then that really corresponds to a raised JVP.
That's right.
Also look at the external jugulars as well. If you see engorged veins over the neck as well, that can often also correspond. It's not as accurate, but it can also correspond with a raised JVP.
That's right. I think the JVP often is a bit of a mystery, and people try and skip it out, but it can tell you quite a bit. And someone who's short of breath, crackles on the lung bases, and you find they've got a raised JVP, then that tells you that they've likely got pulmonary edema, heart failure. Yeah. Now, moving on to the heart sounds themselves, the key part of the cardiovascular examination, listening to the heart. Now, the heart sounds can be broken down into, broadly speaking, the first heart sound and the second heart sound. The first heart sound timing with the closure of the atrioventricular valves, and the second heart sound timing with the closure of the aortic and pulmonary valves. Now, as well as the heart sounds themselves, you also want to listen to see if there's a murmur. And that could be systolic or diastolic, and that could indicate the presence of valvular pathology. Now, we won't go too much in detail in this podcast, but there are other podcasts which are available on our website which go into further detail about the different types of heart murmurs and vascular heart disease.
So, as we said earlier, the heart is intimately related with the lungs, and often problems with the heart manifest as what you would think are problems with the lungs. So it's very important to listen to the lungs as part of your cardiological examination. And what I tend to do to broadly screen for this is I listen to the lung bases after I've listened to the heart. And what I'm particularly looking for there is the presence of bibasal crepitations, which could indicate fluid in the lungs.
Right.
It's an important sign of pulmonary edema.
And in addition to that, as we've already mentioned, looking at the JVP and also looking for ankle edema to look for any peripheral edema. And you can also check at the sacrum as well. The combination of those findings on the clinical examination are highly suggestive of heart failure.
So this is an absolutely dreaded phenomenon, the angry, grumpy consultant at 8 a.m. on the post-take ward round on a Monday morning, turning to you in front of all the SHOs, all the registrars, asking for 10 courses of atrial fibrillation. It's an absolute nightmare, and I can tell you it doesn't get easier even when you're a doctor and you're asked exactly the same question.
No, it doesn't.
It doesn't. However, give yourself some sort of advantage. First of all, it's not that you need experience to be able to do that quickly. But in the absence of that, you can use various classification or sieve systems that allow you to break down the causes into common pathology. So this is one that I like to use. It's the mnemonic Vindicate. So V is for vascular. So in this case, for atrial fibrillation, V for vascular could be, say, ischemic heart disease, which is probably the most important cause.
Yeah.
It could also be, under vascular, I also include other conditions of the heart. So, for example, valve disease. So mitral regurgitation is another important cause of atrial fibrillation. Infection and inflammatory. So that's for I. Here we're thinking about things, say, for example, pneumonia, for example, is particularly associated with the acute onset of atrial fibrillation.
That's right.
And indeed, endocarditis as well can cause it. N is for neoplastic. Now, as you can see, by doing this, we don't get the most common things immediately.
No.
But what we do is we get a more complete list.
And you've got a structure to do it.
Yeah, so indeed, under neoplastic, there are neoplastic processes. For example, atrial myxomas, tumours of the atria, can cause atrial fibrillation. Degeneration is important. Elderly patients can develop atrial fibrillation or idiopathic atrial fibrillation simply because of degenerative changes. Idiopathic and iatrogenic is for I, and certainly, often paradoxically, certain antiarrhythmic drugs often have arrhythmogenic properties and can induce atrial fibrillation.
Yes.
Congenital, there are various congenital conditions associated with AF, which we won't talk about here. I can't think of any autoimmune conditions, however, I'm sure there are some. T is for trauma, and then lastly, E, endocrine metabolic. So there are causes here. For example, thyrotoxicosis would be a very good example there.
And I think it's important to remember that this is not just for the cardiovascular system, but this approach can be applied to anything, really.
Exactly. You can use this sieve in your mind when you're asked the causes of anything.
Yeah.
Another good piece of advice is just to practice. Practice lots and lots and lots. Get asked these awkward questions. Do plenty of questions. EMQ based, SBA based, whatever you want to do. But the more exposure you get to questions, the quicker you'll become at figuring these things out.
And ask each other as well. You can test each other out.
Exactly.
Right. Now here's another dreaded question which you often get asked on the ward round. What tests would you do for this patient who is presented with this particular disease or this particular set of symptoms? Again, the best way to approach this is to break it down into various different modalities of investigation, which can be applied to any disease or any presenting symptom. And the way that I like to think about it is to break it down into cultures, and that's really sort of microbiology, bloods, imaging, scopic biopsy. Now that can vary depending on the system involved. For example, in GI pathology, you might want to do endoscopy. In terms of the heart, we're talking about things like angiography to image the coronary vessels. And then functional is a way of describing investigations which are specific to that particular organ system. And one example of that is the ECG, which of course is a key investigation in any patient who presents with any form of cardiorespiratory signs or symptoms. Now, first of all, cultures. Well, what are we talking about there? Well, blood cultures is one example in cardiology, which can be very helpful in the diagnosis of infective endocarditis. However, there are other things as well, as Ed already mentioned, pneumonia precipitating AF, and so you'd want to screen the patient for any signs of systemic infection as well. Now, moving on to bloods.
Bloods. So basically in bloods you split it up into arterial and venous. Now, as we know, arterial blood looks basically at acid base and gas exchange. Now, because the heart and the lungs are so intimately related, you can get gas exchange problems within the lungs because of heart problems. So the key thing you'd look on your arterial blood gas would be for signs of respiratory compromise or respiratory failure.
That's right.
In terms of the venous bloods, obviously there's lots and lots of blood tests, and usually they're done in a standard fashion. But you need to think, why particularly am I ordering this investigation? And that applies really to any investigation. So for full blood count, one of the reasons you're doing that is because of anemia. You're looking for the presence of anemia, which can exacerbate any symptoms of cardiovascular disease. You're also looking for the presence of raised white cells, because this can indicate associated infection, which can precipitate cardiovascular events.
That's right. Yeah.
And obviously that would also be associated with a rise in the C-reactive protein.
Now, renal function is also very important, particularly in patients who have heart failure, because if you're going to start someone on diuretics, you want to be sure, first of all, that they've got reasonable renal function, creatinine, and also their potassium levels, because many of the diuretics can cause hypokalemia, so that's very important there.
Next, we have liver function tests. Now, liver function tests are not something you traditionally associate with cardiology. However, in the setting of right ventricular failure, you can get an element of hepatic congestion, which can cause derangements in liver function tests. So these do have a role to play.
That's right. And the other thing, I guess, to say is many patients who come into hospital, for example, after an MI, we start on a statin. And it's helpful to know their baseline liver function before giving them the statin so that you can see if there's any derangement.
Exactly.
Next, thyroid function tests. Now, this can be particularly helpful in someone who has atrial fibrillation, because as Ed has already mentioned earlier, hypothyroidism is an important cause of atrial fibrillation.
And then finally, the ESR. Now, ESR is raised in lots of infective conditions and also inflammatory conditions, but particularly in cardiology and diseases of the vascular system, we're thinking about vasculitis.
That's right, yeah.
Particularly temporal arteritis being associated with a very high ESR.
Yeah. Now, here is an example of another key investigation which all patients presenting with cardiorespiratory symptoms or signs should get when they come to hospital, and that is the chest X-ray. Now, in terms of looking at the heart, there are several areas of the chest X-ray which are helpful to look at. First of all, obviously, is the cardiac silhouette. And in someone who has an enlarged cardiac silhouette, like in this particular chest X-ray, and that is greater than half the diameter of the chest cavity. That's right.
That's right. Yeah.
That can indicate a degree of cardiomegaly and heart failure. Another important thing to look at are the lung fields, because someone in heart failure may present with pulmonary edema, and you may get diffuse interstitial shadowing, or curly B lines, or upper lobe diversion. Often there are a sort of classical set of features which you find. It's just a sort of pattern recognition. After a while, you'll see a lot of these X-rays, and you'll be able to see instantly, this patient is in pulmonary edema. They've got heart failure. So it's extremely important. And again, not just from a diagnostic point of view, but you might give the patient diuretics, and you might want to see the response to that. Yeah. And so a subsequent X-ray might help show whether that's helped to relieve the fluid load on the lungs.
Exactly. The next investigation we come to is echocardiography. This is absolutely vital investigation. However, it certainly can be not as easy to get hold of, at least immediately in the hospital as a chest X-ray. But it gives you information both about the structure of the heart, so any abnormalities you may have of the structure, but also certainly about the function of the heart. It allows you to look at how the ventricles are working, how much blood is being pumped out, so what is the left ventricular ejection fraction. You can also, using various additional techniques such as Doppler, look at particularly the flow and the speed of flow across various valves. And this can help you to classify the severity, or indeed to define the presence of valvular pathology, such as stenosis or regurgitation.
That's right. And in addition to valvular pathology, another important use of echocardiography is in patients with suspected endocarditis. Yeah. And as well as having the transthoracic echocardiogram, you can do transesophageal echocardiography, and you get a much better picture than of the heart chambers to see if the patient has any vegetations within the heart or any valvular pathology, and can be incredibly helpful.
These are some more advanced imaging techniques that can be used. The one on the top left is an example of cardiac MRI, and this enables a very high resolution picture to be taken of the heart borders and walls and the valves and things, but it also can be used to image the heart in motion, to further define areas of hypokinesis or indeed hyperkinesis, and to further define valvular pathology.
That's right. And the other image is a myoperfusion scan, nuclear imaging study of the heart, to look for areas of ischemia, and particularly looking for areas of what's known as hibernating myocardium. Ed, tell us a bit about that.
Hibernating myocardium, this is one of the areas that's really taken off recently in nuclear cardiology, is defining areas of hibernating myocardium. What can happen in the setting particularly of ischemia or infarction to the myocardium is that certain areas of the heart can almost become shocked and cannot, because of this, they don't work so effectively. However, these areas are not totally dead, and by defining them and then going in with angioplasty and reperfusing them with blood, they can actually start working again.
Right.
So the important thing is that using these techniques, you can localize certain areas that have the capacity to recover if given the option.
And target those specific
areas,
the blood supply.
Exactly.
Right, okay.
And it's one of the new areas in interventional cardiology.
Now, moving on to angiography, the scopic biopsy part of cardiology. Another very important investigation, particularly in ischemic heart disease, because of course you want to be able to identify which particular vessel it is which has stenosis, or in the case of acute myocardial infarction, which is blocked. And the other important point about angiography is that not only can you image the vessels, but you can also provide therapy. So with angioplasty, you could open up a stenotic vessel, and you can deploy a stent in order to try and prevent that vessel becoming stenosed in the future.
Exactly. This is the whole basis of interventional cardiology.
That's right. Yeah. And functional, the key investigation of cardiology is the ECG. Now, we've got a separate podcast
We do.
on basic interpretation of the ECG. So if you want to know a bit more about that, you can listen to that. But again, a very important test in a patient presenting with a whole range of symptoms and signs, chest pain or syncope. It can help you determine the underlying pathology and even localize it to a particular part of the heart.
Exactly. So finally, let's talk a little bit about management in cardiology. Now, as in any other specialty you want to talk about, management can broadly be divided, or I shouldn't say management, I should say treatment, because when we refer to management we mean investigations and treatment. So when we talk about treatment, it can be conservative, medical, or interventional, and some people will call interventional surgical. In terms of conservative, we are speaking mainly about lifestyle management, so altering the patient's risk factors. So if you know the risk factors for a given disease and you try and alter them in some kind of way, you can alter the natural history of that disease and the propensity to develop complications secondary to the disease. Drugs are obviously very, very important, and Rashmi is going to speak about particular types of drugs in a second, but also particularly to mention interventional. We've already spoken about angioplasty, but it's important to be aware of the presence of surgical techniques, particularly coronary artery bypass grafting. This is an important technique that's used in severe ischemic heart disease. I can't remember the exact criteria, but...
That's right. In fact, interestingly, Ed, I don't know if you've read the New England Journal of Medicine just in the past few weeks. There's a very interesting trial, the Syntax study, which actually tells us a bit more about this. And they looked at a group of patients, almost 2,000 patients, who all had either triple vessel disease or disease affecting the left mainstem. And they found that coronary artery bypass grafting was associated with a significantly reduced rate of mortality than angioplasty. So in those particular patients with triple vessel disease or left mainstem disease, it can be very effective.
Exactly. So, and finally, transplant, and this is particularly useful, say, for patients with cardiomyopathies. That's when you mainly will use transplant.
Okay. Now, talking a bit more about the drugs which you can use to treat cardiological problems. Well, these can be broken down into different classes of drugs. The first set, antiplatelets, anticoagulants, and thrombolytics, are really looking at the constituents of the blood itself in order to reduce further risk of thrombus formation in patients who have ischemic heart disease. And aspirin has really made a huge impact on reducing the mortality following myocardial infarction. Thrombolytic therapy as well, in terms of patients who have had, are having an ST elevation myocardial infarction, but for example might not be eligible to have percutaneous intervention. Now, the other set of drugs, broadly speaking, are drugs which alter or have an impact on the function of the heart, broadly speaking. And these can be broken down into ACE inhibitors, beta blockers, calcium channel blockers, and diuretics. And easy way to remember that is A, B, C, D, which seems to come up all the time when in medicine. And all of these drugs can be used for a variety of different problems, including hypertension and heart failure. And the third class of drugs are the antiarrhythmics, which are used for treatment of arrhythmias, including things like atrial fibrillation, if you want to rhythm control AF, as well as other types of tachyarrhythmias.
So that's it for this introductory podcast to cardiology. We hope you've found it useful. During this podcast, we've looked at some of the important clinical features and how you can break those down. We've looked at the investigations and the typical 5-modality investigative sieve.
That's the cultures and the bloods, the imaging, scopic biopsy, and functional.
Exactly. Yeah. And then finally, we've looked at the key treatment modalities that are available, so conservative, medical, or interventional. So thanks for listening, and we'll see you soon.
Thank you.